Hello, 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 ladies and gentlemen, hello. And today, this afternoon, we are talking about upper respiratory disorders. So, some class outcomes, we will apply the pathophysiology of the upper respiratory tract to patients that are presenting with upper airway disorders. We will identify the importance of performing a complete health history and assessment. We will determine possible complications that are associated with upper airway disorders. We will identify the clinical manifestations of upper respiratory infections. And because we are nurses, we are going to develop nursing interventions for patients with upper respiratory disorders. So, the respiratory system is a complex system that is divided into the upper and the lower respiratory systems. So, air will enter the respiratory system through the nose or the mouth and will travel to the lungs, where respiration is the exchange of oxygen and carbon dioxide between the outside air and the lungs. And this occurs at the alveoli level. So the major function is to supply oxygen and then remove carbon dioxide from the body. So the nurse should complete a thorough assessment, including inspection, auscultation, percussion, and then palpation to identify a dysfunction. So the major function of the respiratory system is to perform the functions of ventilation and then respiration. Ventilation will occur as the air moves into and out of the respiratory system through the act of inspiration and exhalation. So during ventilation, the structure of the respiratory system will filter and humidify the air entering the system. So the process of respiration occurs as oxygen and carbon dioxide are exchanged at the level of the alveoli. After respiration occurs, the circulatory system is responsible for transporting the oxygenated blood to the tissues of the body, and we call this perfusion. In addition to the process of respiration and ventilation, the respiratory system is responsible for the following: acid-base balance. We know the exchange of carbon dioxide for oxygen in the lungs and the renal secretion of bicarbonate maintain the body's pH level between 7.35 and 7.45. Now, ladies and gentlemen, although we talk a lot about lab values, what do I have to know? Does it matter? No, it really doesn't matter, because wherever you work, there is going to be that specific lab value. If you go to LabCorp versus Quest, their values are going to be in the same ballpark, but they may not be exact. However, the one thing that is exact always is 7.35 and 7.45. So please remember that. And then speech. Speech is the movement of air through the vocal cords, allowing vocalization of words. The sense of smell. The movement of air through the nose will allow an individual to smell odors in the environment. And then fluid balance. Water will be excreted as water vapor through the exhalation process. So the anatomy of the respiratory system. So if we follow the path of air through the system, air is going to travel through the upper respiratory system to the lower respiratory system. Oxygen will enter the respiratory system through the nose or the mouth. Within the nasal cavity are 3 turbinates, and these are made of bone and they are covered with cilia. Once the air passes through these turbinates, it will enter the pharynx. The pharynx is divided into the nasopharynx, the otopharynx, and the laryngopharynx. The laryngopharynx will start at the base of the tongue and continue to the larynx. Once the air leaves the larynx, it enters the lower respiratory system via the trachea. So the trachea will divide into the right and left main bronchi. Once the air enters the right or left main bronchus, it will travel to the lobar bronchi. Once air travels through the lobar bronchi, it will enter the bronchioles. Air will travel through the respiratory bronchioles into the alveolar ducts, both of which are lined with alveoli, to the alveolar sacs, and this appears as a cluster of alveoli. So let's talk about rhinitis. So the epidemiology, and so we know epidemiology is the beginning. So the most common problem with the nose and sinuses is rhinitis. This can impact quality of life by causing headaches, fatigue, sleep disturbances, and congestive impairment. I can't breathe through my nose. I'm very congested. Adequate and appropriate management of rhinitis will impact management of asthma, sinusitis, and sleep apnea. And these are all possible comorbidities. So rhinitis can result in widespread morbidity with significant financial impact from medical treatment costs. I have to keep on returning to the doctor, lost work days because I have to keep on returning to the doctor, or I just don't feel well, and then reduced work productivity because I just don't feel well. So the pathophysiology of rhinitis, this is classified as allergic or non-allergic. It can also be classified as acute or chronic. An inflammation and irritation of mucous membranes will line the nose, may also affect the eyes, throat, and ears. Allergic rhinitis is categorized as perennial or seasonal, seen in people with allergies to plant pollen, animal dander, or just plain dust. It will occur in response to exposure to allergens found in the environment, medications, foods, or occupational irritants. Non-allergic rhinitis will present similarly, to allergic rhinitis, but does not involve the immune system. So the most common example of non-allergic rhinitis is the common cold caused by a variety of viruses and is usually self-limiting unless a bacterial infection will occur simultaneously or because of the original rhinitis. Acute rhinitis can last 1 to 3 weeks and can be non-allergic or an allergic reaction. So chronic rhinitis may last up to 12 weeks. So an inflammation and irritation of mucous membranes will line the nose. This can also affect the eyes, the throat, and the ears. Allergic rhinitis occurs in response to exposure to allergens that are found in the environment, medications, foods, or occupational irritants. Foods that may induce allergic rhinitis include peanuts, cow's milk, nuts, eggs, and wheat. Mechanical obstructions within the nose or sinuses, such as polyps, nasal septal deviation, and hypertrophy of the nasal turbinate, or sinus tumors, may also result in the development of rhinitis. So, some clinical manifestations of rhinitis. Symptoms include nasal itching, sneezing, nasal congestion, and rhinorrhea. Rhinorrhea is just a fancy name for a runny nose, which is excessive nasal drainage. So, in chronic rhinitis, symptoms will last 12 weeks or longer with discolored nasal discharge and radiographical evidence of fluid levels within the sinuses. So, how do we manage and then diagnose, or diagnose and then manage rhinitis? So, diagnosis is going to be based on history, the patient's history, whatever they say. When did it start? How long did it last? Do you know what the trigger was? And their symptoms. Treatment and management is dependent on the cause. So, obtaining a history on the onset of symptoms that focuses on the pattern, seasonal aspects, environmental exposures to allergens in the home or work, and precipitating factors will serve as the basis for determining treatment. So, if rhinitis is caused by a virus, medications to relieve symptoms may be prescribed. So, in allergic rhinitis, allergy testing may be indicated followed by a desensitizing regimen. So, referral to an ear, nose, and throat specialist for assessment of nasal polyps, nasal septal deviation, and then hypertrophy of the nasal turbinates or sinus tumors may be indicated. Additional diagnostic testing may include pulmonary function testing to evaluate for the presence of asthma or obstructive sleep apnea. So, some medications for rhinitis. Pharmacological management in allergic and non-allergic rhinitis is aimed at symptom relief. Oral antihistamines, nasal spray antihistamines, and corticosteroids and decongestant medications can assist in relieving symptoms. So, prescription and then over the counter antihistamines are the most common treatment of symptoms of sneezing, rhinorrhea, and then pruritus. So, ladies and gentlemen, listen up, and then listen up one more time. Sedation, performance impairment, and anticholinergic effects such as dry mouth and dry eyes, constipation, and increased heart rate are common side effects of what we call first generation antihistamines, such as Benadryl. Benadryl is a first generation antihistamine because it does cause sedation. Ladies and gentlemen, please continue to listen up. Second generation over the counter antihistamines such as Claritin, Allegra, Zyrtec will have less or no tendency to cause sedation. So, first generation antihistamines are going to cause sedation. Remember Benadryl. Second generation antihistamines do not, they are the non drowsy. Intranasal corticosteroids are the most effective treatment of allergic rhinitis and related symptoms when they are used on a regular basis. There is no systemic effect from the use of intranasal corticosteroid medications. So, we know that when we take a steroid, we get that weight gain, we get fluid retention, we get an alteration in my blood sugar. But when we use an intranasal corticosteroid, such as Flonase, there is going to be no systemic effect. No systemic effect. So, because of that, intranasal corticosteroids may take days or weeks for the patient to experience symptom relief. Intranasal sprays that contain antihistamines can result in systemic antihistamine effects, meaning that sometimes they can become a little drowsy from the inhaled antihistamine. So, saline nasal sprays can be effective in relieving symptoms such as nasal congestion and sinus pressure and their related effects. Saline nasal sprays have no negative effects, and they can be seen with they can be used with antihistamines or decongestants. So if your patient wants a more natural approach that maybe they have to work and they can't take their Benadryl, they are using a steroid, but they're not getting relief yet, so they can use a saline nasal spray. Decongestant medications can reduce nasal congestion and obstruction. Side effects of these drugs include insomnia, irritability, and palpitations. So, use of these drugs should be avoided unless nasal antihistamines and corticosteroids have been ineffective. They should also be avoided in patients with a history of cardiac disease, hypertension, glaucoma, cerebrovascular disease, and cardiac dysrhythmias due to the fact that they cause vasoconstriction. Table 25.1, medications used in the treatment of rhinitis. Please take a look at that table. So, ladies and gentlemen, listen up, and then listen up one more time. Decongestant nasal sprays, such as Afrin, should only be used for a few days at a time, as overuse can cause something that we call rebound congestion. This is severe congestion. So, what happens is I use the Afrin nasal spray and I get relief. and then it's going to wear off. So a few hours later, I want to use it again. But what happens is the more I use it, I am actually hurting myself because then I'm causing this rebound congestion. So although these medications can be used daily, 3 days, 4 days max, no longer than 4 days, they really should not be used daily, meaning daily all day long. That's what I mean. So if infectious rhinitis is present, administration of antibiotics is required with selection of the antibiotic based upon patient history, allergies, and then how severe the infection is. So nursing management of rhinitis. Symptoms of rhinitis are due to irritation and inflammation of the mucous membranes of the nose, resulting in nasal congestion, sneezing, and then nasal drainage. So some nursing interventions for rhinitis. We are going to assess because we are nurses, and we always start with vital signs. Temperature elevation may indicate the presence of infection. Elevation in heart rate and blood pressure may be related to medication used to treat these symptoms. Nasal drainage. Nasal drainage should be thin and clear. However, if it is yellow or green, this could indicate an infection. So what are we going to do? Some nursing interventions. We are going to administer medications as prescribed, oral or nasal antihistamines, oral or nasal corticosteroids, decongestants, and then antibiotics. These will be used to control symptoms of excessive drainage, inflammation, nasal congestion, and then antibiotics will be used to treat the infection. So ladies and gentlemen, listen up, and then listen up one more time. So diphenhydramine, otherwise known as Benadryl, we know this is a first generation antihistamine, and this will have a sedation effect. It will cause sedation. Guaifenesin is a common decongestant, Mucinex, and then fluticasone is the preferred corticosteroid nasal spray, otherwise known as Flonase. So, teaching. We are going to teach this patient the appropriate use of medication. So listen up, and then listen up again. We need to express to them, we need to educate to them to avoid nasal decongestant use for greater than 2 to 3 days, 4 days max at a time due to the risk of rebound congestion. Instruct the patient to complete antibiotic therapy as prescribed to avoid superinfection or the creation of an antibiotic drug resistance. We are going to educate them to avoid the use or coming in contact with known allergens or their triggers, and then, of course, preventing the spread of the infection, which is simply washing their hands. And then how do I know that I've done a good job taking care of this patient with rhinitis? There will be release of symptoms and the expected outcome for the patient with rhinitis. So, rhinosinusitis. In 2007, the American Academy of Otolaryngology, the Head and Neck Surgery Foundation practice guidelines, identified that rhinosinusitis is now the preferred term when referring to sinusitis because it is a more comprehensive term. So, classification is based upon duration of symptoms and including acute, subacute, and chronic. Acute rhinosinusitis is defined as lasting less than 4 weeks. Subacute is 4 to 12 weeks duration. Chronic is more than 12 weeks and may include exacerbations of symptoms. So acute rhinosinusitis is further classified by etiology as either acute bacterial rhinosinusitis or viral rhinosinusitis. So, viral upper respiratory infections that spread to the paranasal sinuses are the cause of most acute rhinosinusitis, which can then lead to a bacterial infection. A deviated nasal septum, trauma to the nose, or tumors interfering with nasal drainage can contribute to the development and of acute rhinosinusitis. Acute rhinosinusitis can progress to chronic rhinosinusitis, which is one of the most common chronic diseases. So, ladies and gentlemen, listen up, and then listen up one more time. Rhinosinusitis is more common in females. However, the presence of nasal polyps is seen almost 50% of these patients. So, nasal polyps are a precursor. It will put the individual at risk for rhinosinusitis or chronic rhinosinusitis because it will happen frequently. So, rhinosinusitis will impact the quality of life due to symptoms and then impaired physical functioning. I simply can't work. So, the pathophysiology of rhinosinusitis is infection and inflammation of the paranasal sinuses. There are 4 paired air-filled spaces that will surround the nasal cavity. Inflammation of the nasal passages will cause vasodilation, increased blood flow, and vascular permeability, reducing the size of the nasal passages. Nasal congestion will occur as a result of swelling of the nasal turbinates. These are the bony structures along the nasal passages that will aid in maintaining moisture and trapping airborne particles. So this will result in obstruction of the nasal airflow. So some clinical manifestations of rhinosinusitis. It is diagnosed by the presence of 3 symptoms: purulent nasal drainage, nasal obstruction, and facial pain, pressure, and fullness. Nasal secretions are colored or cloudy in nature. Nasal obstruction may be reported as congestion, a stuffy nose, or blockage of the nasal passages. Onset of these symptoms in relation to the development of upper respiratory symptoms will indicate ABRS, acute bacterial rhinosinusitis. Additional symptoms may include fatigue, fever, maxillary dental pain, cough, new onset of headache, and ear fullness or pressure. So, nasal purulent drainage may also be noted on the posterior pharynx. Indications of extra sinus involvement will include signs of neck stiffness. This is a possible meningitis, orbital protrusion, cellulitis of the face or the orbit, and then abnormal eye movement. Symptoms that will last more than 10 days without improvement will be considered acute. Management of rhinosinusitis and then diagnosis. This is primarily based upon a physical examination. Medical management will start with the completion of a history and physical examination, focusing on the ears, the nose, the throat, the teeth, the sinuses, and the chest. During the physical examination, the provider is looking for signs of inflammation, tenderness, firmness, or redness. Light palpation or percussion of the sinuses using the index finger is done to evaluate the presence of pain. So, vital sign assessment also needs to be completed to identify temperature evaluation. Diagnostic testing may include a CT, MRI, if patients do not meet clinical diagnosis criteria. On radiographical studies, fluid, thickening of the mucus lining of the sinuses, and the presence of polyps, oocytes, or foreign objects may be found, including the fact that the patient will be diagnosed with rhinosinusitis. So treatment for rhinosinusitis. The focus of treatment is based upon the etiology. Treatment goals will include treating the infection if it is present, pain relief, and then reduction of nasal inflammation. In bacterial infection, antibiotic therapy is required. Caution must be taken to prevent antibiotic use in non-bacterial illnesses such as viral rhinosinusitis to prevent the development of antibiotic resistance. Normal saline irrigation has local effects that will reduce symptoms in acute rhinosinusitis. Normal saline irrigation is beneficial in the removal of infections, debris, bacteria, allergens, and then inflammatory mediators. And so we call this a nasal lavage. So treatment also decreases edema of the nasal mucosa and the viscosity of nasal secretion using this nasal lavage. Delay in initiating antibiotic therapy may be indicated if the patient presents with symptoms of non-severe illness, such as a temperature less than 101 or with mild pain. So treatment is focused on symptom management and then following up. After 7 days, if the patient fails to improve or worsens at any time, antibiotics will then be prescribed. So amoxicillin clavulante is the first-line therapy for most patients because of its efficacy, it is safe, it has a narrow biological spectrum, and it has a very low cost. So in patients with penicillin allergies, such as Bactrim or Septra, Biaxin, and Zithromax are used. In patients who fail to respond within 48 to 72 hours of treatment or who have persistent symptoms, second-line antibiotics may be required. Antipyretics and analgesics are used as needed to control temperature and pain. Use of intranasal corticosteroids will be recommended in patients with a history of allergic rhinitis. Use of a decongestant and normal saline irrigation can be helpful in reducing osteomeatal complex. This is the bony structure around the drainage openings of the sinuses. So obstruction will facilitate drainage of the sinuses. Patients with hypertension should use caution when taking oral decongestants due to their action of vasoconstriction to reduce stuffiness, which can increase their blood pressure. So, medications typically used for symptomatic relief that should be used with caution include antihistamines that may cause drying of secretions, impairing mucus drainage. Topical decongestant sprays, if used more than 3 days, may result in rebound nasal congestion when they are discontinued. So, complications of rhinosinusitis. Acute rhinosinusitis, if left untreated or inadequately treated, can lead to several potentially serious complications that include orbital cellulitis, orbital abscesses, osteomyelitis, meningitis, sepsis, and subdural abscesses. Orbital cellulitis and orbital abscesses occur from transfer of a sinus infection to the area surrounding the eye. With chronic sinus infection, bacteria can infect the facial bones, resulting in osteomyelitis. Meningitis and subdural abscess occur when bacteria passes through the meninges. So, nursing management of rhinosinusitis. Symptoms are due to obstruction in the flow of nasal drainage from inflammation of the sinus lining. Symptoms include a combination of facial pressure, sense of fullness or pain or nasal obstruction, and the presence or purulent nasal discharge. So, nursing interventions for rhinosinusitis, we are going to assess because we are nurses. And again, we always start with vital signs. Temperature elevation may indicate the presence of infection. Increased blood pressure may be a side effect of the decongestants. Physical examination of the mouth, the nose, and just looking at the face. Facial pressure, a sense of fullness or pain or nasal obstruction, and the presence of purulent nasal discharge will indicate impaired nasal drainage. Swelling, redness, and pain around the eyes may indicate an abscess or cellulitis. Palpation of the sinuses, will identify the presence of fluid within the sinus cavity, which results in pain. So some nursing actions for rhinosinusitis. We will administer medications as prescribed, normal saline irrigation, decongestants, and antibiotics. These will be used to control symptoms of nasal congestion, excessive drainage, and inflammation, and then the antibiotics are going to be used to treat the bacterial infection. So teaching for rhinosinusitis, we are going to educate the patient to report their symptoms to the provider. Temperature, increase in pain, change in level of consciousness, redness or edema around the face and eyes can indicate complications of rhinosinusitis. We will instruct the patient on correct medication usage, limiting the use of decongestant nasal sprays to less than 4 days to avoid rebound congestion. And we will teach the proper use of normal saline nasal rinse. This will facilitate, the removal of debris and excess mucus. And then how do I know? How do I know that I've done a good job taking care of this patient with rhinosinusitis? With treatment, patients will have a decrease in and resolution of symptoms such as nasal congestion and drainage, relief of headache and facial pressure, or the sense of fullness. Resolution of a bacterial infection is managed through antibiotics, and it is important that the patient report unresolved symptoms to avoid serious complications of orbital cellulitis, osteomyelitis, or chronic sinus infection. So, obstructive sleep apnea. This is a condition where the upper airway is obstructed during sleep, causing a narrowing of one or more sites of the upper airway, resulting in intermittent breathing patterns. So some risk factors will include the male gender, obesity, cigarette smoking, alcohol use, the patient's age, their gender, if they are between 40 and 65, and females who are going through menopause. Insulin resistance is associated with the severity of obstructive sleep apnea. So, it is present in a higher prevalence in patients with diabetes mellitus. There are increases in the prevalence of the risk factors of obesity and insulin resistance that are associated with OSA. So, the pathophysiology of obstructive sleep apnea. It occurs during sleep as the upper airways narrow or collapse, increasing resistance to airflow. Narrowing can occur in the retropalatal region, retroglossal region, or the nose. So, with the onset of sleep, the normal work of breathing is unable to overcome the increased resistance in the upper airway, causing airway collapse. So, the pathophysiology of obstructive sleep apnea. It is the narrowing of the airway, increasing respiratory pressure and intrathoracic pressure, resulting in decreased ventilation and gas exchange. Ultimately, there will be periods of apnea. During apnea, there is no tidal volume, no movement of air in or out, no gas exchange in the alveoli. Hypoxemia is a decreased concentration of oxygen in the blood. Hypercapnia is an increased concentration of carbon dioxide in the blood. Acidosis and increased sympathetic vasoconstriction activity occur as a result of the decreased tidal volume and apnea. So, some clinical manifestations of obstructive sleep apnea. It is characterized by the following symptoms: loud snoring, witnessed apnea, gasping during sleep, recurrent waking during sleep, or choking. Spouses will often report patients have disruptive snoring and witnessed periods of apnea. 15 or more obstructive sleep events per hour are sufficient to make a diagnosis. Because of frequent sleep disruptions, patients will complain of excessive daytime sleepiness, falling asleep during quiet time, short and repetitive attention lapses, and then taking intentional naps. So management of obstructive sleep apnea. How is this diagnosed? Diagnostic testing will begin with a sleep history, asking questions regarding the history of snoring and daytime sleepiness, a history of obesity, atrial fibrillation, nocturnal dysrhythmias, type 2 diabetes mellitus, heart failure, and pulmonary hypertension place patients at a higher risk. A sleep study can be conducted in an overnight laboratory study or using home portable monitoring. Treatment will require multiple interventions and active participation of the patient. Use of continuous positive airway pressure is the treatment of choice. Continuous positive airway pressure will prevent collapse of the upper airway through the use of pressure delivered through the use of a nasal, oral, or oronasal mask during sleep. A CPAP machine will deliver a continuous stream of positive pressure, keeping the airway open and providing an unobstructed airway. Patients are taught about operation, care, and maintenance of the CPAP machine. Weight management and weight loss is encouraged as a first-line intervention in conjunction with the use of the CPAP. Positioning during sleep in a non-supine position by using pillows is an effective secondary intervention. Avoidance of alcohol and sedatives before bedtime are additional interventions. Oral appliances that are custom made for the patient may be used to maintain airway patency. Oral appliances will assist with mandibular repositioning to hold the mandible in a forward position to keep the airway open. So, some complications of obstructive sleep apnea. OSA is recognized as a mediator of cardiovascular disease because of recurrent hypoxemia, the release of inflammatory mediators such as endothelins, and insulin resistance. In response to hypoxemia, inflammatory mediators are released, which leads to adherence of white blood cells to the endothelium, causing endothelium damage and then atherosclerosis. Severe nocturnal hypoxemia can result in cardiac ischemia, myocardial infarction, stroke, atrial fibrillation, heart failure, and sudden cardiac death. Surgical management of obstructive sleep apnea. Surgical procedures are classified as primary or secondary interventions. Surgical procedures are considered primary interventions for patients with severe obstructive anatomy that surgery can correct. Surgery is considered a secondary intervention in patients who are intolerant of CPAP or oral appliances. Surgical procedures will remove excess tissue in the airway that interferes with sustaining adequate airflow. Bariatric surgery to facilitate weight reduction is also a consideration. Symptoms are due to relaxation of soft tissue in the upper airway, resulting in occlusion of the airway. Because of the occlusion of the airway, the patient will snore, and periods of apnea occur. During apnea, there is no oxygen exchange, resulting in hypoxemia and then hypercapnia. So, nursing interventions for obstructive sleep apnea. We are nurses and we will assess, and we always start with vital signs. Hypertension and dysrhythmias are common findings due to hypoxia and release of inflammatory mediators as a result of the apneic episode. We are going to monitor height and weight because obesity is a risk factor. Sleep, rest, and then activity history. We will assess for edema, bleeding, and respiratory distress post-op if a surgical option has been pursued. Surgical procedures will put the patient at risk for bleeding. Procedures in that area of the body may cause respiratory distress if swelling occurs. Nursing actions. We will administer medications as ordered. Patients may have uncontrolled hypertension or cardiac arrhythmias. We will do, or doctor will do, diagnostic testing, but it is our responsibility to educate the patient on that diagnostic testing. And then teaching, patient education. We will teach them the disease process. We will instruct the patient on medication use, instruction on the CPAP. Ladies and gentlemen, we will instruct the patient on relaxation exercises to reduce uncomfortable feelings from the mask. We will instruct the patient on weight reduction and management, again, because obesity is a risk factor. And then how do I know? How do I know that I've done a good job taking care of this patient with obstructive sleep apnea? Weight loss and the use of CPAP at night may help to control OSA. Patients who are well managed will verbalize improved sleep patterns, fewer nighttime awakenings, less daytime sleepiness and fatigue, improved mental alertness, and less irritability. Patients with hypertension will have control of blood pressure values will be achieved. So, laryngitis. Laryngitis is the most common disorder of the larynx. Causes include upper respiratory infection, environmental pollutants, gastroesophageal reflux disease, otherwise known as GERD, or use of asthma inhalers. Vocal misuse can result in acute laryngitis, and attempts to maintain speech can further strain the vocal cords. Vocal strain can occur from prolonged periods of talking, which may be seen in teachers, lawyers, nurses, anyone who talks all day long. Endotracheal intubation may cause laryngeal edema, and lung or throat cancer can manifest as laryngitis. So, the pathophysiology and clinical manifestations of laryngitis. It is an inflammation of the mucous membranes of the larynx. Predominant symptom is hoarseness, but can also include symptoms similar to those of an upper respiratory infection, such as a cough, postnasal drip, fatigue, and malaise. Symptoms will typically last 7 to 10 days. Endotracheal intubation may cause laryngitis, which may lead to stridor. So, ladies and gentlemen, listen up, and then listen up right now. Stridor is a high-pitched, wheezing breath sound that is caused by turbulent airflow in a partially obstructed larynx. It is caused by airflow obstruction, and it is a medical emergency. Ladies and gentlemen, please take note. So, management of laryngitis, diagnosis. Diagnosis is based upon patient complaint of hoarseness related to a current or recent upper respiratory infection. Patients may require visual examination of the larynx by an ear, nose, or throat specialist with a laryngeal mirror or fiber optic laryngoscopy. If polyps, inflammation, or tumors are present, X-rays or a CT may be required. So, treatment for laryngitis. Treatment consists of voice rest, adding moisture to the air in the home with a humidifier or vaporizer, and drinking plenty of fluids. Avoidance of smoking and exposure to secondhand smoke is also important. Use of antibiotics is indicated if bacterial infection is present. If laryngitis, lasts greater than 5 days after appropriate treatment and voice rest. Evaluation for the presence of malignancy should be considered. Nursing management for laryngitis. Symptoms are due to inflammation of the larynx resulting in vocal hoarseness or the absence of voice. Additional symptoms may include dry throat, difficulty swallowing, and eating, fever, cough. So some nursing interventions for laryngitis. We are nurses again, so we will assess, and we always start with vital signs. Temperature elevation may indicate an infection. We will assess the throat structures. Increased edema of the throat structures could compromise patency of the airway. And then, ladies and gentlemen, please listen up, and then listen up one more time. We will assess for the presence of stridor. Please remember that stridor is a medical emergency. It will indicate acute obstruction of the airway, and it may require that the patient be intubated, or if stridor is occurring post-intubation, they need to be re-intubated. We will administer humidification as ordered. Humidification may be ordered to reduce inflammation, and administer antibiotics as ordered. Antibiotics may be ordered to treat an infection. And, ladies and gentlemen, we will have emergency airway equipment readily available. Hoarseness, ladies and gentlemen, please take note. Hoarseness and stridor post-extubation indicate acute obstruction of the airway. And again, it is a medical emergency. Your patient may need to be re-intubated. And we need to provide alternatives for communication, such as a pen and paper, a communication board, or if the patient can use it, a cell phone. And teaching, patient education. We will instruct on medication use, instruct the patient on voice rest and the need to use alternative modes of communication. Continued use of voice will cause strain and delay resolution of laryngitis. We will encourage that they increase their fluid intake. And then smoking cessation. Smoking will irritate the larynx and can exacerbate symptoms. And then how do I know? How do I know that I've done a good job taking care of this patient with laryngitis? There will be return of the patient's normal voice, and resolution of accompanying symptoms will reflect resolution of laryngitis and the effectiveness of treatment. In patients who develop acute laryngitis post-extubation, resolution of stridor, ease of breathing, and adequate oxygenation levels will indicate decreased obstruction and then the resolution of the laryngitis. So, laryngeal cancer. Risk factors will include tobacco and alcohol use, poor dietary habits, a compromised immune system, genetic syndromes, occupational hazards, gender, age, race, and again, GERD. Use of tobacco in any form is the most important risk factor for development of cancers of the head and neck. Cigarettes, pipes, cigars, and all forms of chewing tobacco raise the risk because of the chemicals contained in tobacco products. Alcohol ingestion combined with tobacco use will increase the risk up to 100 times. So in patients with a history of alcohol abuse, poor dietary habits are also often present, resulting in a lack of fiber intake and foods containing vitamins. More common in people who have compromised immune status as a result of immunosuppressant drugs after an organ transplant, hereditary diseases. Occupations where workers have intense and long exposure to certain chemicals, wood, coal, or steel dust, or paint fumes and asbestos are at a higher risk. It is slow growing. More than half the people are diagnosed over the age of 65. So the pathophysiology of laryngeal cancer, I'm skipping ahead. Laryngeal cancer usually originates from the squamous cells that will line the larynx and the hypopharynx. Changes in the squamous cells from irritation, usually from heavy drinking and smoking, result in the squamous cells becoming precancerous. According to the American Cancer Society, most precancerous cells do not become cancers if the irritant is removed. So, clinical manifestations of laryngeal cancer: hoarseness or a change in the voice that does not resolve in 2 weeks. Voice changes include lower than usual pitch and raspy and hoarse sounds. Additional symptoms will include a persistent sore throat, constant cough, pain with swallowing, ear pain that does not go away, difficulty swallowing, trouble breathing, a lump or mass in the neck, and weight loss due to difficulty eating. So, medical management of laryngeal cancer. Diagnosis. Diagnosis will start with the completion of a thorough health history, including general health information, other medical conditions, onset of symptoms, risk factors, and the patient's family history. Physical assessment of the neck, thyroid, lymph nodes, and muscle movement of the neck can indicate if tumor growth has invaded these structures. If initial findings are suspicious for laryngeal cancer, referral to an ear, nose, and throat specialist or a head and neck surgeon will be made. So, diagnosis of laryngeal cancer. Diagnostic procedures will include endoscopy and imaging. Laryngoscopy allows for the assessment of the vocal fields and glottis for the presence of ulcerations, nodules, polyps, strictures, bleeding, or tumors. This is performed under general anesthesia, at which time biopsies or suspicious tissue may be obtained for evaluation. Diagnostic imaging will include a barium swallow, a chest x-ray, CT, MRI, and a PET scan. Barium swallow will evaluate the throat and the ability to swallow. Chest x-rays are obtained to evaluate the lungs for the presence of lung cancer. The CT, MRI, and PET scans are completed to determine the presence of metastasis into the surrounding and distant soft tissue, and for regional adenopathy or lymph node involvement. Information obtained through biopsies and diagnostic imaging is used to determine the stage of the tumor and disease progression. Laboratory testing is also done to provide information about the overall health status of the patient. Complete blood count, a CBC, blood chemistry, profile, coagulation studies, and urinalysis will provide vital information about the potential spread of laryngeal cancer, nutritional status, and organ function such as the kidneys and the liver. At present, there is no specific blood test or marker to assist in diagnosing laryngeal cancer. If cancer is diagnosed, prognosis is dependent upon the stage of the disease, the size, location, and grade of the tumor, and the general health status, age, and gender of the patient. So, treatment for laryngeal cancer. Based upon factors such as stage of the disease, location and size of the tumor, and whether the current tumor is a reoccurrence. So treatment will include radiation therapy, surgery, and chemotherapy. Radiation therapy is used to eliminate cancer cells and maintain the structure and function of the larynx. It is used to treat small tumors, reduce tumor size prior to surgery, or used in patients who are unable to undergo surgery. It is usually given 5 days a week for 6 to 8 weeks. Side effects of radiation include increased hoarseness, prolonged tissue healing, a sore throat, difficulty swallowing, and if the salivary glands are involved, a dry mouth. Care should be taken with the patient's skin. No harsh soaps or lotions. A soft bristle toothbrush to decrease the risk of irritation or inflammation. No acidic or spicy foods. Chemotherapy can be used in several different ways. It can be given at the same time as radiation therapy. We call this chemoradiation, and this can improve the effectiveness of the radiation therapy. Can be given before radiation therapy to shrink target tumors and make radiation more effective. It can be given prior to surgery to shrink a larger tumor that is not easily excised. Can also be used as a palliative intervention to help to control the cancer and relieve symptoms, and we call this palliative chemotherapy. So, surgical management of laryngeal cancer. Surgical procedures will include laser surgery, cortectomy, partial laryngotomy, and total laryngectomy. Goal of surgical treatment is to remove the tumor and maintain the function of the larynx, speech, swallowing ability, and, of course, breathing. Laser microsurgery is used to treat early forms of glottic cancers and is now considered the standard approach at many facilities. Results in good functional outcomes and causes will minimize morbidity. Cortectomy is the removal or part or all of a vocal cord through the use of a transoral laser. If cancer is present unilaterally on the vocal cords and is in the early stages, this option may be considered. So, partial laryngectomy is performed to remove part of the larynx in the early stages, and this is removal or of part of the larynx, only one vocal cord, and then the tumor. Preservation of the voice, which may be slightly altered or hoarse, is achieved because of the presence of the remaining structures. Patients will retain normal breathing and swallowing ability, and temporary tracheostomy may be required to protect the airway. Ladies and gentlemen, please listen up, and then listen up one more time. Total laryngectomy is the complete removal of the larynx. In advanced stages where the cancer has spread beyond the vocal cords, it is a curative procedure. The larynx and several rings of the trachea are removed. Swallowing ability will remain normal, but results in the inability to speak. Creation of a tracheostomy is required for breathing and because of the risk of aspiration of fluids and food after removing the epiglottis. Please take note of this slide, ladies and gentlemen. Survival is based upon timing of diagnosis and if there is metastasis to the lymph nodes or other organs. Early diagnosis has a high cure rate with a 5-year survival rate of approximately 80 to 95%. Advanced staging at diagnosis has a 5-year survival rate of approximately 25 to 50%. Other factors that will influence survival rates will include the patient's general health, age, immune function, and the presence of comorbidities such as diabetes, heart disease, or hypertension. Smoking cessation is another factor that will increase survival because of the age of patients diagnosed, usually in the 60 to 70-year age group. Cause of death may be related to other causes other than the laryngeal cancer. So, smoking cessation, ladies and gentlemen, listen up, and listen up right now. Medication therapy for smoking cessation, first line, would be nicotine replacement therapies, including gum, patches, or lozenges. And then non-nicotine therapies such as Chantix, or Zyban. And then second line would be clonidine and nortriptyline. Ladies and gentlemen, please know this slide. Also, for smoking cessation, we can recommend behavioral and counseling therapy. Providing support increases the likelihood of success and can be in the form of group or individual counseling or telephone conversations, telephone support. And then physical activity. Increasing physical activity will decrease cravings and symptoms of anxiety, depression, and stress that may be experienced during smoking cessation. Increasing physical activity and exercise can also reduce weight gain post cessation. And then nursing management of laryngeal cancer. We are nurses and we are going to assess. Symptoms are dependent upon the location of the cancer. It will affect the vocal cords, resulting in changes in voice quality and character or hoarseness. A lump in the neck, earache, or sore throat can be seen in tumors above the vocal cords. So we are going to continue to assess. We are going to complete a review of their risk factors. We are going to focus on smoking, alcohol use, and occupational exposure to any chemicals. Review their symptoms, their complaints, hoarseness, earache, and sore throat lasting several weeks. Will need further evaluation. Skin assessment, red, tender, peeling skin may result with radiation therapy. Patients should avoid the sun during radiation therapy. It will be helpful to wear loose clothing to avoid skin irritation, and patients should be educated to use a mild soap. Checking their oxygenation status, shortness of breath, and decreased pulse oximetry may indicate edema and increased secretions postoperatively at the operative site, putting their airway patency at risk. We will administer chemotherapy as ordered and tracheostomy care. Ladies and gentlemen, please listen up, and then listen up one more time. We will institute aspiration precautions. Post-operatively, the patient is at risk for aspiration because of removal of upper airway structures and the epiglottis. We are going to provide means for communication. Post-laryngectomy, the patient will not be able to speak due to the removal of the larynx. So we need to provide pen and paper and a communication board, a cell phone. We need to make sure that the patient has a means of communicating. Nutritional support and calorie count, small, frequent meals throughout the day. Ladies and gentlemen, please take note. Because of swallowing impairment and necessary surgical interventions, the patient may not have adequate nutritional intake for wound healing. And then patient education, teaching, diagnostic testing and interventions such as the direct laryngoscopy, disease management, understanding the outcomes such as loss of speech and creation of a tracheostomy will be essential. And then tracheostomy management. Suctioning trach and stomach hair is essential to keep the airway free from secretions and avoid infection. Means of communication, because of the loss of vocal cords, the ability to speak will be gone. Alternative forms of communication will be necessary. And then chemotherapy and radiation side effects as necessary. Management will be facilitated through patient education. And then how do I know? How do I know that I've done a good job taking care of this patient with laryngeal cancer? Post-laryngectomy, patients can return to normal activities using alternative means for communication. Patients are at risk for reoccurrence if they continue to smoke and use alcohol. So, ladies and gentlemen, and talking about the patient that is undergoing radiation therapy for laryngeal cancer, oral care is especially important in patients whose salivary glands have been affected. So, a decrease in production of saliva, which may be permanent, can occur, resulting in dry mouth. So, changes in taste, sensation, increased risk of dental cavities, and oral infections can also occur. Patients will be instructed to increase oral intake of fluids, especially water, which can decrease discomfort. So, ladies and gentlemen, listen up, and then listen up one more time. Encouraging the patient to suck on hard candy or chewing gum may be helpful. Patients are instructed to use a soft bristle toothbrush and to brush and floss after each meal and at bedtime. Patients are instructed to examine the oral cavity for signs of infection, ulcerations, or bleeding. And then avoidance of foods that are spicy or acidic, and extremes in temperature are encouraged. Ladies and gentlemen, please take note of this slide. And then the patient that is undergoing chemotherapy for laryngeal cancer. Ladies and gentlemen, please listen up and pay attention. The nurse will monitor fluid and electrolyte balance, weight, intake and output, and encourages intake of fluids and small, frequent meals. The nurse also monitors the patient's white blood cell count for signs of neutropenia and the platelet count for signs of thrombocytopenia. If the patient has a decrease in either count, the patient is placed on neutropenic precautions or bleeding precautions. And patients are encouraged to avoid crowds and persons with infections and instructed to report increases in bruising, blood in the urine or stool, or increased fatigue. Ladies and gentlemen, please take note of this slide. And then, how do I know that I've taken care of this patient well that is receiving chemo, radiation? The location and treatment required, chemotherapy, radiation, or surgery, and the presence of metastasis will determine my outcome. In patients where early detection has occurred, a complete recovery can be expected. And if metastasis has occurred, the outcome is dependent upon the metastasis site and the patient's response to treatment. So, laryngeal trauma, first, is rare. It comprises less than 1% of all blunt traumas. It is partially due to the protected location of the larynx, which is a hard, bony structure of the cervical spine posterior and the mandible in a superior and anterior position. So it is well protected. It is seen in females because of our slimmer, longer necks. And males will present with the highest percentage because of a greater participation in body contact sports. So the pathophysiology of laryngeal trauma, it occurs as a result of blunt or penetrating injuries, ingestion or inhalation of caustic agents to the neck, or pressure from prolonged endotracheal intubation. Blunt trauma can occur as a result of assault, crash, injuries, falls, motor vehicle accidents, sports, or strangulation. Penetrating injuries will occur from stabbings. Laryngeal trauma may be seen in the presence of cardiovascular, neurological, respiratory, or intestinal injuries. Patient outcomes are dependent upon early recognition and maintenance of an adequate airway. Some clinical manifestations of laryngeal trauma will be dependent upon the extent of the injuries: hoarseness, pain, stridor, difficulty breathing, difficulty swallowing, or bloody sputum. The airway can become obstructed from edema or fracture of the laryngeal structure or hematoma development. because of the potential of cervical spine injury in addition to laryngeal trauma, stabilization of the cervical spine is vital. Diagnostics will wait until the airway is protected and the cervical spine is stabilized. Cervical intervention, if necessary, will include evacuation of a hematoma, repair of the lacerations, and stabilization repair of a fracture. So, medical management of laryngeal trauma, diagnostic and medical surgical management. Ladies and gentlemen, please listen up, and then listen up one more time. Diagnosis is completed by conducting a physical inspection of the neck for signs of swelling, discoloration, subcutaneous emphysema, tracheal deviation, or an open wound. Diagnostic studies will include a cervical CT, fiber optic laryngoscopy, or a flexible bronchoscopy. However, ladies and gentlemen, please take note. Priority of care is insurance and maintenance of a patient airway. Maintenance of the airway may include endotracheal intubation or tracheostomy. Please take note. Nursing management of laryngeal trauma. We will assess, because we are nurses, symptoms are due to injury to the vocal cords and edema to the soft tissue of the neck. So, ladies and gentlemen, please listen up, and then listen up again. The patient may have a change in quality and character of the voice, or hoarseness, difficulty swallowing, or breathing. Discoloration and edema of the neck increases the suspicion of laryngeal trauma. So, nursing interventions for laryngeal trauma. We are nurses, so we are going to assess the physical assessment of the neck and the upper airway. We are going to identify risk for laryngeal trauma. If discoloration, change in voice, stridor, use of accessory muscles for breathing, or restlessness indicating hypoxia is present. And then we are going to begin with vital signs: increase in respiratory and heart rate, decreased oxygen saturation, and tachypnea will indicate respiratory distress. Ladies and gentlemen, please take note. Nursing actions. You will have a tracheostomy, insertion tray, and emergency equipment at the bedside. The patient may have a sudden loss of the airway requiring emergency tracheostomy, and you will provide humidified air via a face mask or a face tent. Cool humidified air will help to decrease the airway edema. Ladies and gentlemen, please take note of this slide. You will keep the head of the bed elevated at 45 degrees or greater. Elevation of the head of the bed will assist in decreasing edema and maintaining a patent airway. And then aspiration precautions. You will maintain an MPO status to protect the airway, of course, in the presence of edema and or bleeding. And then teaching patient education. Symptoms to report to the healthcare provider and when to seek emergency medical care. So, ladies and gentlemen, a compromise in airway patency can quickly progress to airway occlusion and death. Maintain voice rest. Limit talking to prevent an increase in the trauma in the larynx and to prevent edema. And then how do I know? How do I know that I've done a good job taking care of this patient that has laryngeal trauma? Early recognition of airway compromise is key. The nurse will provide close monitoring of respiratory rate, effort, breath sounds, and oxygen saturation. Keeping the head of the bed elevated and providing adequate humidification will assist in decreasing edema to the area. And then encouraging the patient to observe voice rest will help to minimize additional irritation and avoid airway compromise. And ladies and gentlemen, thank you. Thank you so much for your time and attention. And as always, please reach out with any questions, comments, or concerns.